I gather that there's an idea that repeated movement testing, which is the backbone of Robin McKenzie's methodology, is a trial and error attempt, meaning move this way and see if you're better. And it really isn't that. It's an investigation, it's a form of testing, and at the end of the day, it's an algorithm. And where you go based on the previous test is informed by the results of the test, meaning it's not just, did it make you feel better? If not, try this. There's a thought process to what happens because of the test and how I will proceed with the next test. And at the end of the day, if the test proves that your symptoms and mechanics are improving, then that test is considered the treatment. But I want to go through a specific example that's simple yet quite common. So for this hypothetical patient, he or she has central and right low back pain, and I will not get into the specific history, I will not get into mechanisms, etc. But we're thinking that this person has a mechanical joint derangement. We've ruled out red flags. We don't think it's inflammatory. We don't think it's structural. We think it's one of the 80% of patients whose spinal problem is mechanical, meaning a joint's not moving well, therefore creating the symptoms and therefore creating the signs of lack of mobility, lack of strength, possible nerve tension, and possibly a functional baseline like I can't sit, I can't sleep, etc. So for this patient, the symptoms are just local to the spine, central right low back pain, and then mechanically, let's focus on the movement of the low back. There are 4 primary movements that I test. So for this hypothetical patient, there's a minimal loss of flexion with producing the patient's pain. When it comes to flexion, toe touching is not perfect for the low back assessment insofar as many things are being tested when I ask somebody to toe touch. Hip mobility also has to be sufficient, thoracic mobility, hamstring, etc. So there's many things. However, it is reliable because I'm looking for change. I'm not looking for what it is. I'm looking for, will it change? Because if we increase the low back flexion and toe touching with movements of the low back, that incriminates that it was limited because of the low back. We were not stretching the hamstrings. We were not flossing the sciatic nerve. We were not moving the thoracic spine as much. So the changeability of a baseline is the important part. Some baselines, obviously, when you take the first test, it's very informative, like a ligamentous test, and the ligament is not there and the joint moves without any stoppage, or a picture of a fracture. Some baseline tests are end-all be-alls, but when it comes to range of motion, it's not that informative too much at the beginning. It's more informative how it changes. So for flexion, because I'm asking people to put their hands on their legs and go down as far as they can touch, I will ask the patient, is that your normal or not? And sometimes they have no idea, but sometimes they're like, oh no, I can usually palm the floor, and now I'm just getting to my ankles. So I'll write in my chart where the patient's fingertips reached. And then based on what the patient says, or based on what I can glean, if the patient has no idea what his or her normal is, I'll write down if it's a minimal loss, moderate loss, or major loss. For flexion though, it's really easy to say reaches distal knees or ankles or floor, for example. So minimal loss of flexion with pain. The second motion I test is extension and standing. So we're gonna say there's a moderate loss of extension with stiffness only across the back, and then left side glide and right side glide, tested actively and passively. They go really far and there's no symptoms with that. So based on that, this hypothetical patient will attempt in this experiment repeated lumbar extension in lying on his or her stomach. For this example, let's just say we do 30. And then the patient, which is enough to kind of understand the effect, meaning it's more than 10. So I typically get 20, 30, 40 repetitions in of a certain movement before I decide if it's worth continuing. Obviously, if someone gets markedly worse with 10, we are stopping. You can think of it as like red lights, yellow lights, and green lights. Red lights are some indication that we're definitely stopping. Peripheralization of symptoms, extremely worsening mechanics, worsening intensity of symptoms. But most people do not fall into that category after 10, 20, or 30 repetitions. Some do, of course. Repeated movement testing relies on understanding what are red, yellow, and green lights. But for the sake of this example, the person does 10, it's a green light, 20, it's a green light, 30, it's a green light. Now let's say we reassess the mechanics. So we're going to pretend in all these cases that the symptoms remain the same after 30 lumbar extensions in line, just to make it easy and to show the difference in how we interpret the testing based on mechanics alone. So for example 1, symptoms are the same, but the mechanics, the person has now increased her extension. So before there was a moderate loss of extension, now there's only a minimal loss of extension. But if the symptoms are the same, and there's a slight improvement in extension loss, and all the other motions are the same, side glides are still full and pain-free, flexion is still a minimal loss with some pain, this would be an indication for forced progression. And I've talked about the 5 levels of forced progression. So we started with the patient just doing extension on her stomach. So a forced progression from that, which is level 1, would be adding the hip sag, meaning getting to the top of the extension, locking the elbows, dropping the hips, and sagging all the way to the floor. If we'd already done that, then the progression of forces would be clinician overpressure. So the person's going into that extension with some external overpressure. It could be my hands, it could be a belt, it could be a towel, etc. But for this person, if they are getting a slight improvement in mechanics, but symptoms are the same, I will likely, not always, each patient is different, but likely the algorithm is pushing me to, I think we have the right motion, we're not losing side glide or flexion, so we're not making the joint more obstructed, and we're loosening it up in extension. I think we need some more force. Another possibility would be more time, but for this example, more force is probably the thing I would go to next, because it doesn't seem unsafe to progress force in the large majority of these kind of examples. So that's example 1. Example 2, same 30 extensions on the stomach, symptoms are still the same, but mechanics, now the patient has lost extension, so we've lost range of motion, and we've lost flexion with increase in pain. So for this patient, because side glides are still full and pain-free, but we're losing range of motion in the sagittal plane, this would make me start to think that I need to look at flexion. So extension is going backwards. We're getting worse with going backwards in the sagittal plane. So my thought process with repeated movement testing is we probably need to test going forward. And as I've alluded to before, and I did a video on a case report about a flexion responder, under 10% of patients with mechanical joint derangements in the low back need flexion, but they do exist. Flexion we can look at 3 ways, primarily lying on the back, bringing the knees to the chest, seated flexion, and of course standing flexion, which is toe touching. So for this scenario, worsening mechanics in the sagittal plane, not the frontal plane, not the transverse plane, we're not testing that. This person, we will change the direction in the sagittal plane and see what happens. Again, cause and effect, do some flexion, see what happens. For joint derangements, I want to point out, changes are rapid, meaning minutes to hours to days. If we're on the right track, we should see changes quickly. And even if we're on the wrong track, we should see changes quickly. The person gets up and now they're worse mechanically. The changes in a joint derangement are characteristic of a joint derangement, the rapidity of it. I do not expect tendinopathies to change quickly. I do not expect structural lesions like bony stenosis to change quickly. I do not expect herniated discs that are structurally compromised, not amenable to directional preference movement, not to change quickly, or I don't expect them to change quickly. So repeated movement testing is informing the diagnosis, and one of the keys to that algorithm is that if something changes quickly for better or worse, and we're trying not to make the person worse, but of course sometimes that can happen, is the nature of testing. If something changes quickly, my antenna go up and I start to think, I think this is a mechanical problem. Of course, you can get false positives where someone changes quickly, but then it just returns to the mean. Changes and then returns, and that's a different scenario. But this rapid change is not unexpected, and if you see it, you should start to think joint derangement. Now, if you're not doing the correct movements to elicit that change, you're going to not think it's rapidly changeable, and pursue other diagnostic theories or ideas. So you need to know how to apply repeated movement testing. And that goes for, of course, any testing in medicine. The clinician needs to know how to apply the test correctly. And as I said before, doing a Lockman test or a McMurray or a carpal tunnel test, they're quite easy. You can even look them up online and do them kind of well yourself. But repeated movement testing is more of an algorithm, and it requires more clinical skills. It requires more clinical decision making. So scenario 3, the patient does the 30 extensions on her stomach, and now symptoms again, still the same. Let's focus on mechanics. But the mechanics now, everything else is the same, but we're losing right side glide. We now have a moderate loss of right side glide going to the side, whereas before it was full and painless. Now we have a moderate loss and it's painful. So we haven't affected the sagittal plane, but we've considerably affected that frontal plane. So for me, because we've started to obstruct the patient in a frontal plane that we were not obstructed in before, I'm going to start testing lateral movements. Meaning, I don't think the answer is in extension or flexion. It might be in flexion, but I don't think it's an extension. So we need to look outside of the sagittal plane, and there's 3 main ones we use in that lateral plane, notably hips off center extension, so extension with a little bit of a side glides on the wall, or flexion and rotation. There are others, but those are the main ones that we will look at. So that's how the repeated movement testing informs where we go. For patients who buy Robin McKenzie's book, Treat Your Own Back, it walks you through this process to an extent. But a clinician who's versed in using repeated movement testing is not just saying, are you better? If not, oh, let's try exercise 12. They're really going by, this is what's happening. So I think either now we need to go to force progression. We have the right direction, but we have the wrong amount of force. And that could be also going to sustained as a different progression of forces. Or we have the right plane of motion, but we definitely have the wrong direction, or we're not even in the right plane. And that's why repeated movement testing is repeated, because you could do 30 extensions in lying and the person feels the same, but mechanics are getting better. But once you do 100 or 200 or 500 over the course of a week, then you get your real answer. So that's what I want to impart to patients, is that we need to understand the effect of doing it repeatedly, a lot. And so we can get a snapshot after 30, but we really don't get a good idea until you've done multiples of that. And then obviously, if there's something that's exacerbating the symptoms, possibly moving in the other plane in your life, we need to address that to allow for this to take effect. So there's kind of like 2 sides of the coin. If you need extension, we might likely need to reduce the amount of flexion in your life to get a better idea of it if extension is fruitful. Because if you're doing lots of extension, but you're also doing lots of flexion, they could cancel themselves out and we wouldn't get a good idea about whether or not we're on the right track. So repeated movement testing means repeated. It's my job as a clinician to see if there is a movement, that's the directional preference, that will restore that joint to normal, abolish symptoms and signs. And I do that by adding different motions and assessing the effect and changing the movement based on the effects.